call. All right, well, good afternoon, everyone. This is Brandon Gare with the National Minority Equality Forum. Thanks again for joining us this Friday afternoon or morning, depending on where you're coming from. Just good to see you guys again. It's been a couple of weeks since we've been here. We had the summit, and then last year we did a program with Mia and her folks at the American Medical Association. So it's just good to be back with you all, and glad that we have such a good group that's not only presenting today, but also participating and following up. So I'd like to go ahead and first of all, thank Dr. Burley, who's a member of our advisory board and helping us put this together. So we really appreciate that. And now I'd like to turn it over to Dr. Mia Keys, who's gonna lead us in this conversation. So thanks, everyone.
You're about a year early with the doctor part, but I take that and we speak it into existence. I'm very happy. Right. I'm very happy, Brandon, as always, to be joining the National Minority Equality Forum family, where you and Dr. Puckrin and Keiko and the whole team just do a consistently great job with setting up these conversations. These really very critical conversations. And today we couldn't be talking about something more significant at the intersection of COVID-19 and prevention, and then also HIV. We'll bring in some conversation also around faith and faith-based medicine as our panelists today, who are very special, are going to just give us some great commentary. So foremost, I just want to introduce Dr. Stefan Wallace, who by training is a research epidemiologist, and he's recognized internationally for his work as a social justice leader, as a public health leader, especially given his over 2 decades of experience within sexual health and public health prevention across a diversity of populations. And he's also the Director of External Relations for the COVID-19 Prevention Trials Network, which is what we will predominantly be talking about. And he's also serves in leadership with the HIV Vaccine Trials Network as well. We also have joining us today, Ms. Danielle Campbell, who is a member of the faculty at the Drew University School of Medicine and Science in the Department of Preventative and Social Medicine. She's also a research analyst at the University of California at the Los Angeles campus, and we of course keep California in our minds, particularly Northern California, in terms of what they're going through. But what Ms. Campbell will bring to us today is her perspective as a socio-behavioral scientist, as a public health strategist, and really all of the work that she's been doing to influence structural systems and overall paradigms of power as it relates to the production of health inequities among racial and ethnic and sex gender minoritized populations. So we're really quite excited that she brings her experience today. I'll also mention that she's a community organizer for HIV/AIDS and sexual and reproductive health. And last but certainly not least, I might be a little biased, but this is one of my favorite people in the world, very close friend of mine, Dr. Ulysses Burley, who is the founder of the UB the Cure, LLC, which is the overall consulting company on the intersection of health and human rights. And then overall, he brings in such a very thoughtful approach to his work. I always tease him, he's a native Houstonian, and I don't really feel like Texas really brings it with respect to the sports situation, but UB is certainly cream of the crop as it comes to overall public health service. And he's a physician by training, but brings the public health initiative. And as Brandon mentioned, he is a 40 under 40 cohort member of myself and others, countless others, some of whom are in the audience today. So I'm going to hand it over to Dr. Wallace to start us off today. And we've got some really interesting questions that we're going to put forward. And audience members, just as a reminder, if you have questions, please drop them in the Q&A box below. If you want to just start discussion or comment on what our panelists are saying, put it in the chat. So questions below, chat in the chat. Okay? All right, Dr. Wallace, I will hand it over to you, sir. Welcome.
Thank you. I guess I just want to start by introducing the Coronavirus Prevention Network, the CoVPN, as it's abbreviated. was established by the National Institute of Allergy and Infectious Diseases, part of the National Institutes of Health, to enroll thousands of volunteers for large-scale phase 3 clinical trials, looking at testing investigational vaccines and monoclonal antibodies to protect people from COVID-19. This network really leverages the expertise of 4 existing clinical trials networks: the HIV Vaccine Trials Network based here in Seattle, Washington, the HIV Prevention Trials Network based in Durham, North Carolina, the Infectious Diseases Clinical Research Consortium based in Atlanta, Georgia, and the AIDS Clinical Trials Group based in Los Angeles. These individual networks continue to perform the clinical trials for HIV vaccine and prevention and other infectious diseases, in addition to their new COVID-19 roles. In short, the CoVPN provides the infrastructure, research teams, data, and community engagement experience needed to efficiently coordinate and support large-scale studies and analysis.
Dr. Wallace, I'm wondering, can you give us just an overview of why there's a need for significant community engagement with respect to COVID-19 and trials and so on?
There is, for lots of different reasons. It's important to all of our clinical trials networks, all of the networks that are involved in the CoVPN, that communities are centered as part of the process of the conduct of any clinical trial. And many of us have, been doing this work for a while, recognize the importance of ensuring that communities are also informing our operational processes, as well as the design and implementation of these clinical trials. In part because, we move on the understanding that participants in trials are really community members, are not just the end users of products, but have assets, have strengths, have capacity to help inform the science as well. And so engaging communities as partners as part of the process is inherent to the work that we do. Additionally, what we understand is that involving communities, involving groups who would benefit from a research process in the process also means that the results of the process are owned by the community. So if an approved vaccine were to, if a vaccine candidate were to be determined to be safe and efficacious and to be approved, it would more likely be acceptable by the population because they were involved in helping to develop and implement the trials that led to this particular product.
Yeah, that makes perfect sense. I'm wondering what our audience thinks about this. And so I'm wondering, audience, if you all can just answer a question for us via our poll, which will pop up on your screen. Would you participate in the COVID-19 clinical trial? Yes, no? Would you need additional information to make a decision? Let us know. You can drop that right there. Thank you, Dr. Wallace. Are there other things that we should consider before we open the conversation up to Ms. Campbell to also give us some remarks?
Yeah, I would just offer that the CoVPN has organized a comprehensive strategic plan to sort of guide how we're doing the work of engaging communities. And this work is sort of multi-pronged. Part of it is the development of mechanisms to ensure that community is involved forming the design and implementation of these studies. We have those mechanisms as the expert panels that represent different key populations. And these expert panelists are researchers, clinicians, and experts in the areas of social and behavioral science, bioethics, and their clinical physicians and scientists as well. These are external persons who are really reviewing and providing feedback to these protocols that are being implemented. And so that's one mechanism. Another mechanism that Danielle's a part of is the community working group, which she'll speak to. And certainly the design and development of materials and assets that can be deployed in communities to support information dissemination, ensuring that people get accurate information about what is actually happening. And we have a huge stakeholder portfolio that involves engaging lots of different groups, including the National Minority Quality Forum and the and physician networks, including the American Medical Association and the National Medical Association, as well as other groups, advocacy groups, HIV prevention groups. And so there's a massive approach and plan to this. And the document that all of this sort of rests in is on our website, www.preventcovid.org. You can download the strategic plan in both English and Spanish, and really be able to review it in more depth.
Yeah, and I will say I can attest to the massive effort that Dr. Wallace is referring to coming from AMA. We're really excited for all that you're doing and look forward to continuously being a partner. And so I want to come back to our poll question and see where the audience falls. So it looks like we have about a little more than half of people are saying additional information to make a decision. So I'm hoping that by the end of this conversation, people will have a bit more information, and maybe we can go ahead and come back to that question later on. But in the interim, Ms. Campbell, I'm wondering if you can tell us a bit more about the CoVPN community working group and your role as a member, and where you see the impact of the working group falling right now and to come. And welcome.
Welcome, and thank you all for the lovely invitation to impart these words with you all today. It's been quite the experience living through this pandemic. It's just something to behold as we prepare for life post-COVID, right? If there's ever such a thing. So Stefan spoke very eloquently about some of the efforts of the CoVPN, and where the CWG fits in with that is, I guess, is the experiential arm. So we are the manifestations of community members who are representational in this pandemic. So I can say personally, community engagement is critical for me as the family member of an individual who was diagnosed with COVID early on in the pandemic, if we can ever recall back that far, right? Given that this is year 500 of 2020. And we lived with COVID during a time where there was not good science, or there was not robust science, I'll say, and strike the good comment. There was not robust science around some of the efficacy of the treatments that were experimental and justly so. So we lived through the hydroxychloroquine with the side effects of blindness, and we didn't know very much about what to expect as a result of his being treated with hydroxychloroquine or other therapeutic agents at the time. So my relationship with this epidemic is a bit different than other folks who may be represented in this space at this time. And so that propelled my work on the CWG to really be a part of the synthesizing of some of these research protocols that come across, translating that information back to communities most at risk, like Black males here in California, where the epidemic or the pandemic still is not flattened, right? Being a part of being part of conversations where front-facing materials are being developed and disseminated into communities most at risk, and just representing those most marginalized and disenfranchised health communities. So being a member of the working group, for me, and what community engagement means, it means it's a sharing of a power dynamic, right? It's centering those who have experience and who have affect of COVID at the center, right? It's centering those lives and experiences. So it makes it that much more critical for me to be a part of this work and other global efforts, in addition at the federal level as well.
Thank you for that, Danielle. That made some things really quite clear. And I know that there are some follow-up questions in the chat box. I will get to them. We'll incorporate them throughout our conversation. You spoke about engaging those who are historically not necessarily engaged when it comes to trials. And one of the ways that has proven, or at least research has demonstrated that that there's an effective entree is going through where people spend a lot of their time, right? Including faith-based spaces. And so I'm wondering if you can talk to us a little bit, Dr. Burley, about some of the things that Danielle mentioned, and particularly with respect to your role as a faith-based ambassador.
Yeah, absolutely. Thank you. I'm speaking it into existence, Dr. Keys, and thank you both, Dr. Wallace and Ms. Campbell, for your remarks. As mentioned, I am the founder of UBD Cure, which is an organization that operates at the intersection of faith, health, and human rights, where we treat people and not just disease. And I founded UBD Cure from my own experience as a healthcare provider, realizing that what we did in hospitals alone was not enough to meet the full wellness needs of our communities, and that there needed to be more engagement and more attention given to the social drivers of disease. And so, as a person of deep faith, my pursuit of that complete wellness, if you will, not only for society, but for myself, quite frankly, has been largely informed by my very prominent or the very prominent themes of healing and the sanctity of life in my own faith. And so it's with that understanding that I have partnered with the CoVPN to integrate these principles of wellness and public health, but also in faith, so that we might change the pandemic from the inside out, and in doing so, impact people's whole health and whole wellness. As you know, COVID-19 has impacted entire communities. And those communities include Black, Latinx, and Indigenous people of faith. And we understand, and the CoVPN understands, that oftentimes it's our faith that informs other aspects of our life, including how it is that we engage our health and wellness, but more specifically, how it is that we engage science in our healthcare system. And so, based on the previous work of the HIV Trials Network, and engaging faith communities in that work, I'm so grateful that that offshoot has now emerged for this work around COVID-19. And as I've already begun to engage faith communities, it's becoming apparent that it's necessary that we continue to invest in this work, not only of just community engagement, but also meeting people in the community around their belief systems. So I look forward to talking more about how me and my colleagues, there are 6 of us, and we have been deemed Faith Initiative ambassadors who cover the span of the entire United States and a multitude of faiths. We all have the capacity to speak to the intersections of faith and science, and to lift up faith communities as hotbeds, if you will, of conscientious and factual information that we might be able to share around not only COVID-19, but the solution or the way out of COVID-19, which as of right now seems to be a viable vaccine.
I want to stick with you for just a moment, Dr. Burley. So you talked about the continuum of spirituality and science. When you are having these conversations within faith structures and among faith communities, where's the tension, or how does the tension play out? And where also are there major connections where people are able to hear both spirit and science?
Yeah, absolutely. So first, in my work around engaging faith communities in ending the HIV and AIDS epidemic as a public health crisis, there has always been, at least in Christianity, this tension around what healing looks like. And so, in many stories in the Gospels, in the Christian Gospels, Jesus engages in these healing ministries, and oftentimes these acts of healing are instant. And people go from sickness to instantly being well. And so you'd be surprised at the amount of people who identify with that as the way in which we are to be healed in our current day contemporary reality. And so then for people living with HIV and AIDS where there is no cure, what does healing look like for a disease that we don't yet have a solution to, but a disease that we have medications for, that when people have access to them, they can live whole and healthy lives and keep the people around them whole and healthy as well. So what does healing look like for Christians then who are living with HIV and AIDS? And then now, what does healing look like for believers who are suffering from or impacted by COVID-19, where again, We don't necessarily have viable treatments. Just yesterday, the first treatment was approved by the FDA for COVID-19. But where we see this vaccine as being the solution out of it, what does that mean to a person of faith that identifies with healing in a certain kind of way? And so that has been a part of the tension, and some of the role of us as faith ambassadors is to address that tension head on, and then to provide some relief in saying that science is something that is God-given. And in many respects, the parallels between science and faith are one and the same, in that both have been geared towards the sanctity of life, the preservation of life, and life abundantly. And so, again, these theologies around healing has arisen as I engage faith communities. But there's also been hope in faith communities because of their faith, right? Because I've endured worse situations, and it was my faith that kept me whole and that kept me sane through those situations. And I believe that my faith will sustain me even again through COVID-19. And so there've been both positive aspects as well as a lot of hesitancy as it relates to people's belief systems around COVID-19 and the medical science that potentially can get us out of the pandemic.
Thank you. That was really quite vivid. And I also appreciate that you mentioned that you're working with six altogether. There are six of you all together, and you're working across faiths. So this is an interfaith initiative, is what I'm hoping also everyone understands. And so you mentioned faith and belief. And so I want to go to Ms. Campbell and Dr. Wallace and talk a bit more about what tactics work even within non-faith-based communities. Where are the sources of hope with respect to healing, the theologies, but in a secular, using the secular terminology for theologies and beliefs around healing and deliverance from COVID-19? Where are the tensions, and what are the hopes, and what are the strategies that work when you're working with communities to talk about COVID-19 and getting involved in trial vaccines and overall just raising awareness?
Go ahead, Danielle.
Okay, you can take it, Dr. Wallace. I'll chime in there after, if that's okay.
Yeah, so the strategies and the tensions are there. The current pandemic that we're in is politicized, and the clinical trial process is absolutely politicized. And so there's real concern there about the safety and wellness of people considering participating in clinical trials, and what does it mean? There's tension also between people who are living with HIV and considering the COVID-19 pandemic in general. So I think there's concern there in that regard. I think, for many communities that have or bear the burden of various chronic conditions, diabetes, hypertension, and other conditions that, the CDC and other groups are saying puts people at greater risk for COVID-19, I think that there's concern and tension there as well. In the clinical trial space, I can just briefly say that the health and safety of participants is paramount to our process, and that there are several mechanisms in place to protect the safety and wellness of participants. And it really starts during the informed consent process. Before people even become participants in the study, they get an opportunity to hear what are the risks of potentially participating in these studies? What are the benefits? How might I be taken care of if something happens to me while I'm in the study? The study sponsors are required to cover medical care for people. And as a function of participating in a COVID-19 clinical trial, you get, of course, access to care and treatment should you contract COVID-19. But in addition to that, you also get access to COVID-19 testing throughout the process at no charge to you. So I think that that's another consideration that I think is important for people to be aware of. But beyond the medical piece, I think that there's a mental health and there's a mental piece to this as well. And that this pandemic is ravaging our communities, and we're sort of, as Black folks, but in particular, but also for other groups, we're wrestling with the impact of the pandemic on top of systemic racism, on top of police killing of unarmed people, on top of discrimination in settings, on top of under insurance or discrimination in the workplace for LGBTQ people. So there are a lot of social conditions that many people are grappling with in addition to the current pandemic that I think are worth discussing as well.
Ms. Campbell.
Thank you for that, Dr. Wallace. You gave a beautiful setup and segue. So my work works in the space of translation. So it's being able to translate some of the nuances of the developing science, which is a challenge within itself. Like we're literally watching the book be written as it's written. And so there's a huge learning curve when you talk about translating science to communities that are already mistrustful of a system due to the very isms that were described previously. So part of being able to translate science and address the lived condition of individuals is doing just that, addressing, acknowledging, validating individuals' existence. I can tell you that the message is received much more potently when you meet people where they are and address their human related social, and to that, bring with you some information that may or may not be useful to that individual community, but it's showing up, it's maintaining a presence, it's being able to distill down large, complex scientific principles into bite-sized bits of information that are consumable for individuals to help, further the science, and justifiably so, but contextualize that within a burgeoning epidemic, to get folks to COVID testing centers where you have, culturally competent and culturally reflective staff members who can appropriately perform the tasks needed to get people tested, to get them aware, to get them plugged into online resources like those that are offered via the CoVPN, but to also bring that level of relatability to say, hey, I'm a member of this working group that does this great science in partnership with this trials network, right? I've rested my career in HIV and understanding dynamics of power around sexual and reproductive health and translating how it's symbiotic with what we see rolling out here with COVID. So I think that's one of the most effective ways to really reach those communities that are in the margins where the mistrust is so rampant, and justifiably so.
Yeah, I mean, you're hitting on so many different points here, particularly that mistrust part is significant, right? But I hope what people are hearing when you talk about mistrust, you're not saying that mistrust causes inequities. The mistrust is usually in response to the situations that have themselves perpetuated within communities a mistrust, right? So I hope we understand that causal pathway, or at least that correlation. There's one that precedes the other, and especially because Dr. Wallace was talking about ongoing disparities and inequities. And by the way, plug for the AMA, we just yesterday released a report on the existing inequities with respect to COVID-19 amongst Latinx populations. And we can provide that in the chat if you all are interested in reading it. I want to ask the audience, because Dr. Burley mentioned that the FDA had just yesterday approved a vaccine, right? And so we want to know through a poll, or excuse me, Danielle, you're reacting.
Treatment.
Not approved. It's yes.
Yes. Called
Thank you.
Treatment, not vaccine. Yeah.
Treatment, yes. Thank you. So let's go ahead, Danielle. You were going to say something?
I wanted to be sure that we were clear and not conflating what's available to individuals and who this specific treatment is available for, which populations rather.
Thank you. Absolutely. I hope Actually, can you repeat that one more time so that, because I feel like I muddled all of that for you. Go ahead.
You did not. So we wanted to be sure that we were clear about the FDA's most recent ruling and that remdesivir was approved for a specific population of individuals with COVID, those who are hospitalized.
Yes.
So remdesivir will be available as an option for treatment of COVID-19.
Correct. So we do want to know if beyond this, the FDA were to approve treatment for, well, rather a vaccine for all, would you take it? Yes, no, or do you need additional information? We'll give that a couple minutes just to see where people fall. But I want to stick with you, Ms. Campbell, and tell us a bit more about, you were talking about meeting people where they are, the human aspects of COVID, and you yourself recovered from COVID-19, right? I'm wondering if you can share with us some of the things that brought you hope at the time where you were going through, and what do you feel, especially given your professional work overall, what do you feel, or who do you feel are additional messengers that whom we haven't spoke on today, but that they should be tapped into and you all work with through the working group?
I think that's a really dynamic question. So individuals that that have not been invited to this space, right? So I'm thankful for all of the individuals who are here as a part of this conversation. And I cannot stress enough that these are the sine qua non with which we would not be able to have as much progression that we have in this conversation that we have. But I think individuals who may be missing, I can say housing authority individuals, right? So where you see the largest burden of COVID-related epidemic amongst those individuals who are housed in multi-generational spaces. So if you reach out to the individuals that control that framework, it seems like an unlikely pair. But if you can engage those individuals to make those spaces safer for folks who are housed in multi-generational housing, I think that's one way to strike at COVID, providing that, again, fundamental education. And what was important for me as I watched family go through the COVID epidemic was relatable medicine, relatable providers who would be transparent in translating the information about what the science was saying at that time. So the science around COVID is very, very dynamic, and it literally changes daily. Just yesterday, as was mentioned, we have a treatment option available to certain individuals who are hospitalized. Today, that's celebratory, in my humble opinion. So what was most relatable is being able to speak, confidently and clearly and receive those messages from providers about what's available in terms of life-sustaining options, like it's a beacon.
I want Dr. Wallace, please, to expand on what you're saying, because you're making critical points, particularly about the role of providers in terms of what's available. And so, can you tell us more about what it means to work with private practices, and what can private practices in particular do to help increase testing rates, and also involvement with clinical trials?
Yeah, I think providers, particularly private clinics and general practitioners who may be part of a group, or those even in hospital or larger FQHC settings, have an opportunity to increase testing. I think what we saw in the beginning was reports of many people of color being turned away from testing and being turned away from opportunities to get care because their symptoms weren't taken seriously. And I think that there's an opportunity for clinics to help change that and the provision of care in communities. Many of us understand that there is an implicit bias framework that exists in the medical establishment. And I think it's really important, for community providers, particularly for provider networks and particularly those of provider networks of color, to respond and really show up in this time to ensure that communities are getting access to not just COVID testing, but are also being referred to for clinical trials. Because we understand that, similar to the mistrust that Danielle noted earlier, that there's also a diminished, or I should say that Black folks generally are not referred to clinical trials, are not referred to participate in clinical trials, and so it's a sort of two sides of the same coin conundrum. Because if the provider perception is I don't need to ask this person because I believe they're not going to participate anyway, because that is a pervasive attitude in our culture, then that also limits people's participation ability to even learn that clinical trials are happening or what the trial is or what it means. And we understand that there's quite a bit out there in terms of the data that talks about people having trusting relationships with key people in their lives. And medical doctors are part of that relationship dynamic that people tend to trust. And so I think that's another reason why it's really important for providers to step up and to really help to support this process, and not just in terms of referring people and educating their patient populations about clinical trials, but also ensuring that there's access to testing and treatment and care.
Dr. Burley, you're a trained physician, and so I'm wondering if you can talk to us about, in your estimation, what are likely some of the, for lack of a better term, sources of ignorance that providers might be grappling with in terms of, as a provider, this is what I'm concerned with. I'm concerned with the body. And I'm concerned with the space of traditional medicine within clinical settings, right? When it comes, however, to COVID-19, when it comes to HIV, and Ms. Campbell laid it out quite well, there are these other social and structural factors that matter. How do you envision working with providers who are very comfortable working within the clinical setting, but are less comfortable with engaging on some of these larger structural social issues, especially if they've never received the training or haven't been taught to value it throughout their course of medical practice?
Yeah, I think from a broader perspective, we have to reform medical education, first and foremost. That includes training around social determinants of health, but also include a level of awareness around cultural competency. We know that when persons of color, particularly Black people, are treated by people who look like them, their health outcomes are better. We have research to suggest that. And so we also need to increase the access for medical education for Black people, like nurses and physicians and scientists and technicians and all other sectors of healthcare. We need to increase the access of healthcare in urban and rural communities to make it be more accessible for communities of color. And so, if you're a provider right now, you cannot treat first HIV and AIDS without understanding the factors that happen upstream to lead to these downstream events. And likewise, you cannot treat COVID-19 without understanding these upstream factors that then lead to these downstream events. You have to be aware that, people of color, particularly African Americans on the south side of Chicago, for instance, likely have higher incidence of asthma because of redlining, historical redlining, right? And because our urban communities have been built near highways and communities where the temperature is higher, where then infection thrives, or hospital deserts, right? You have to know that before you even diagnose the person's dis-ease. And so that's why one of the mandates of You Be the Cure is to treat people and not just disease, because we understand that their health outcomes are attached to much more than just what they present with medically. And I understand that adds another layer of education for a profession that already requires a lifetime of education. And so, we get from many providers, why is it that I have to learn more about cultural competency or the social determinants of health. But I think saving a life is a huge task and a huge responsibility, and sustaining life as well is a huge task and a huge responsibility. And so we have to be willing to stretch in our profession so that we can provide the best wellness outcomes for diverse communities, understanding that what's making them sick likely isn't something that can be diagnosed in a hospital.
Really appreciate that charge, that it's not just saving a life, it's sustaining quality of life and recognizing everything that happens beyond the body that impacts the body. Really appreciate that. There was a question earlier, this is for Ms. Campbell and Dr. Wallace, because I think, Ms. Campbell, you mentioned very briefly some of the impact that we know so far about hydrochloroquine, for instance, and you mentioned that blindness is potentially a side effect. Right. And so can you briefly talk to, between the two of you, some of the ways that health and safety of participants in clinical trials is being protected? Dr. Wallace, you mentioned some of this earlier, but if you can just tie some of those points. People are afraid, right? And so, can you help us to address that?
Yeah, I just want to just offer that the clinical trials process is sort of separate from the treatment of COVID-19, which is the hydrochloroquine conversation. So within the clinical trial context, again, I mentioned the informed consent process where people get to understand what the potential risks are for participating. And how the mitigation of that happens is when a person shows up, presenting with symptoms for anything, they have an opportunity to get care and treatment from the clinic that they are participating in the study with. And that if there's a need to get care for symptomology or for other things outside or that exceeds the clinic's capacity, then they're referred to a general practitioner. And again, these are situations where costs are usually not the responsibility of the participant. The other thing I will mention is that the institutional review boards at all the institutions where there are sites participating in the trials are independent persons who have to review and approve these clinical trials in those institutions. And so as an investigator, as a researcher myself, I can't just go off and do a clinical trial without going through sort of an independent body of experts to say whether or not, this study makes sense, whether or not it's ethical, whether or not, people are being protected and such. And so that's the other piece. The other thing is that during the study, there's this protocol safety review team that reviews any indications of people coming up with symptoms, whether they're related, whether it's perceived to be related to the study products or not. Like all of these things are being documented and being monitored, not just by the researcher performing the study at that site, but also by an independent group separate. And then there's the Data Safety Monitoring Board, which reviews all of this data for the entire trial in an unblinded way. And so this group is an independent group of experts who, again, are outside of the clinical trial context. And they're reviewing all of this. And if they determine, for example, they're seeing some events, some symptoms pop up, some what we refer to as adverse events pop up. If they're at a serious grade level, then the DSMB can stop the study or pause it in order to investigate whether or not these events that they're seeing that are being reported through the clinical trial site are related to the study product. That's another part of it, right? So, I mean, if we find out, for example, that a particular product is causing more people harm than potential good, then the DSMB would stop the study and potentially say, hey, this study can't continue because it's going to cause, harm as opposed to good. And so there are quite a few different mechanisms put in place to really protect study participants. And I just want to confirm that. The other thing I will mention, because, this comes up a lot, is about Tuskegee. And what I will offer, in response to that is that Tuskegee was an absolutely terrible experience. And it absolutely did not have to happen the way that it did. And I think that what we can do and what we can learn is that informed consent is really important. I think the critical thing for folks to understand about the Tuskegee experience is that those participants did not consent for that study. They did not provide consent. They were not told about the risks. They were not told about, what would happen to them as a result of their participation. And there are policies and federal laws in place now to prevent that from happening. And there are regulatory bodies who are monitoring these processes within the clinical trials to prevent this from happening. And so, we live in a world where they're full of people. And certainly, we can legislate and we can create laws to say that, this shouldn't happen, this is unethical, this shouldn't happen. I think one of the other important pieces that Danielle, I'm sure, has spoken to or can elaborate more on is that the role of communities, and another reason why it's important for communities to be involved in these processes, is to be an additional ethical mechanism in place to help ensure that if potential participants are involved, and not just as participants in studies, but also involved in helping to design and implement the studies, then they can also be another set of eyes that's watching this process to make sure that things are not going to go crazy, that that researchers are going to do anything unethical. And that's not to say that researchers can't be trusted, but with processes as sensitive and as complicated as clinical trials, in my opinion, it's always good to have lots of eyes on the process, particularly community eyes.
That's the translational bit I think Ms. Campbell was getting at earlier. And help us, yes, please.
And it extends to the functionality of the CWG, right? We are the external community watchdogs. And as an individual who is a seated voting member on an institutional review board, this experience, this lived experience, this trained experience gives value added to those discussions when you talk about oversight. I'm also an individual that consents participants into trials on a daily basis. So as Stefan mentioned, right, being knowledgeable, being reflective, being human in the approach to enrollment. And when you give someone the initial consent, right, because informed consent is not just a document, it's not sort of a one-shot deal. Informed consent lives throughout the mechanism of the trial. It is a continuous, reliable conversation that builds trust between the investigator, the staff who are on the front lines doing this work like myself, and additionally, the participant and the institutions that are trusted to conduct this research. So it should be an iterative process, but Stefan spoke about internal and external controls that are meant to provide safety for participants, and not only participants, but staff and accountability to infrastructure as well. So these are very, very critical discussions. And so we must not forget Tuskegee, but we must also address those internal and external controls that have been validated with rigor, right? To protect participants as we move the conversation beyond frameworks of mistrust and distrust.
Yubi, you had something to say.
Yeah, I just want to affirm this conversation around the equity that those of us on this call, but also the many experts that have been recruited for this effort around engaging communities of color, how equity is important in terms of how people receive the science. And so before my life and work of advocacy, I too conducted clinical trials in allergy and asthma for people of color, mainly in Chicago. And one of the reasons why they were willing to engage in that was because they felt like they were making or entering into an agreement with someone they could trust simply because we shared an experience culturally, ethnically, or racially. And that was the sole reason that I was in that position, if I'm honest. I was the only physician of color in the department. And so I ran the clinical trials that specifically recruited Black and Latinx individuals. And a large part of our success was for the simple fact that I feel like you're someone who can relate to me. And because of that, I will trust you in this process. Likewise, in my engagement of faith communities around the CoVPN Faith Initiative, a common refrain that I am hearing after our discussions, after our talks, is that it feels good to receive this information from you, as in from somebody who looks like me. I don't necessarily know you, but I feel like maybe I can trust what you have to say simply because we share a lived experience that you can't create anywhere else because of the skin that we inhabit, or because of the gender that we inhabit, or because of the sexuality that we inhabit, or because of the faith that we express. And so, again, it's critically important that we're not only engaging people at the clinical level, but we're also doing so at the relationship level, and those relationships take place in community, which again is why this community engagement strategy is so important in the work of ending COVID-19 as a public health pandemic.
I'm so grateful that you mentioned that. I want to put a pin in this conversation around homophily is what you're referring to as a community engagement and rapport building strategy. Let's really quickly pivot back to the results of our poll question. Whether or not you would participate or would you take the vaccine were it to be approved by FDA. And similarly to the first question we asked, most people are saying they would need additional information to make a firm decision, although we do have a little more than a quarter who are saying yes, they would take it. And so I'm wondering, Dr. Wallace, what are your responses to that? What additional information would you want to offer?
Well, I think it depends on what additional information is needed.
Mm-hmm.
I think people, the approach of this for people is in places. There are different levels of considerations, and people might decide to consider participating to support, finding a response and finding an end to the pandemic. They might, say it's important because, as was mentioned, I might live in a multi-generational, household, and I'm concerned from that perspective. Some people might, because of pre-existing conditions, health conditions, they might think that it's important for them. So I think the approach is different. So it would be important to understand what information is needed. And I would encourage persons who are considering this and who have additional questions to, again, follow up on our website, the FAQ section, or to reach out to any of us to get more information.
So thank you for that. Let's go back, and this is a question for all of you to jump in on. So Dr. Burley was talking about how when there is a shared experience between patient and provider, whether that experience is based on racial alignment, on sexuality, on faith, so on and so forth, lived experience, shared lived experience, there tends to be greater compliance and adherence to medical regimes, or at least within the clinical space. And there are similar reports and research that say that transfers over into just engaging in the medical space, right? Clinical trials are also implicated there. Can you all just briefly speak to that? In your estimation, in your experience, how has that mattered? Has it mattered?
Well, as I commented, I saw it firsthand in my own work, how beneficial it was. And the data suggests as much as well. And so, separate from this conversation, I think as we consider policy in our country moving forward, as we continue to engage this ongoing conversation of reparations for people of African descent in the United States, I think we should entertain what those reparations might look like, and that maybe reparations are unfettered access to medical education for Black communities who want to pursue that avenue, so that we can increase the level of Black and Latinx and Indigenous populations in healthcare. And in doing so, I believe we will see a greater engagement from communities of color with a healthcare system that has implicit bias and that has historically been untrustworthy. And so, all of these intersecting narratives, right? This isn't just about COVID-19. This is about a future of health equity. This is about, access. This is about the social determinants of health. And these are things that can be impacted at the policy level, but we have to identify them as issues that need addressing. And I believe that, COVID has provided us a moment that has exposed the inequalities in our country and how those inequalities manifest medically to then translate into an unequal pandemic. So we're starting to see legislation, representatives out of California, as Danielle can speak to, early in the pandemic presented, a bill to mandate the social determinants of health be funded through the CDC, right? So we actually start putting resources toward studying and researching what happens outside of hospitals and laboratories. And so we have to continue to grow those conversations so that we can increase this relationship capital between the community and our healthcare system.
Well said. Well said. And I invite Ms. Campbell or Dr. Wallace to offer any additional points if you wish. So why don't we do this? We've got 3 minutes left on our really very significant conversation. I wish we had a bit more time. I want us to collectively revisit the first poll question, which asked whether or not you yourself would participate in a clinical trial for COVID-19. As we're waiting for the poll to close, and I'm going to close it out with you, Dr. Wallace, I want to lend the mic to Dr. Campbell, to Ms. Campbell, to UB, and then come back to you with any closing remarks, anything that you want for our audience to take away.
Sure, I'll start. The elephant in the patient room, the elephant in the boardroom, the elephant in the courtroom is racism in the United States. It's the elephant in the room as we address COVID-19. But in the prominent words of Archbishop Desmond Tutu, there's only one way to eat an elephant, and that's a bite at a time. And I hope that these kinds of conversations continue to be small bites into the elephant in the room that might change people, change their viewpoint, such that these poll results reflect that, right? And so at the beginning of these conversations, people say, yeah, I need more information, but maybe by the end of just a few more felt more comfortable about what they had heard to be able to make an informed decision, then we will have done our job in taking a small bite out of that elephant in the room to the point to where there is no elephant left in the room. And so I'm hoping and looking forward to that day. And I hope that this offering has played a significant role in how people move forward around COVID-19, but also vaccine science.
Thank you, Dr. UB. Danielle.
Thank you. So it is my hope to continue on this conversation around moving past, right? What is unknown is that folks who are participating on this webinar and who are in earshot of the words that we've delivered today will take it upon themselves to continue to engage in this effort, to educate yourselves, to ask the questions of those who are on the ground and in the ivory towers and on the Zoom calls at 6 a.m. who are working feverishly to not only work with systems of power to develop a treatment, to develop a vaccine, to take great care that research is conducted ethically amongst those populations who are representative in this pandemic. Take care to ask us the questions that you need. Invite us out to give talks and conversations like the one you're plugged into today, and to realize that we are people and this pandemic continues to rage on amongst people. people who exist within ecological systems, and we have needs. So us coming out to you today is a demonstration of our commitment to this work and putting an end to this pandemic amongst populations of individuals, all individuals who look, breathe, love, and feel like us. So thank you.
I love that. I love that. Thank you so much. Let's open up the poll results so that Dr. Wallace can take those into consideration when he closes us out. So let me just remind you of the statistics of the stats from the first time we answered or asked this question. The first time there were 28% yeses, and then 21% said no, and then 89% needed additional information. Now I will say we've had additions since the beginning of asking this question, but overall, there's been a reduction in those who said they needed information, probably by about 40 or so odd percent. And so, yeah, I'll leave that to you to consider, Dr. Wallace.
Thank you for that. I just want to clarify something that I said earlier in case it wasn't communicated correctly, that the idea that study-related injuries are covered in clinical trials is something that's sort of a provision, it's a federal policy. And the COVID care that people may need to receive would need to be covered by, their own providers or their own insurance or their own sort of mechanisms. Separately, I think that it's important that communities understand that there are more ways to engage in clinical trials aside from being a participant in the study. That I think that's the thing that I hope everyone sort of walks away from this conversation with, that participation in the clinical trial is not the only way to be engaged. And that you can be engaged by helping to support the clinical trials that are happening. You can be engaged by being a part of CABs at local clinical trial sites. You can be engaged by learning more about the trials that are out there and how to communicate those and convey the messages accordingly to communities. You could also support the process and be involved by getting involved in the CoVPN and any of our clinical trial sites to support, as Danielle talked about, the translation of this information and really being the accountable community voices to the design and implementation of the trials. So there's lots of different ways to be involved aside from being a participant in the study. And I guess if there was a last thing that I would say, it would be that in order for us to move out of this pandemic, and I put a comment in the chat earlier, we need to get the clinical trials, we need to get them done, and we need to get the products tested, obviously, but we also want to make sure that we get diverse representations of people in the clinical trials so that we understand how the clinical trial or how the products are working in different communities, and so that we can generalize the results across populations.
Thank you for that. That was quite the closing word, and just overall a really very dynamic discussion. I think I can speak on behalf of the audience to say that we appreciate all of the wise words you've brought today, and we hope that we can continue to expand this conversation. For those who did not catch the conversation in its entirety, it will be made available via the NMQF YouTube page, and so just stay involved with NMQF to learn about additional conversations. But for the time being, I just want to say thank you to Dr. Stefan Wallace, who is the CoVPN and HIV Vaccine Trials Network Director of External Relations and Community Engagement. We're also quite grateful to Danielle Campbell, who is a CoVPN Community Working Group member, and also to Dr. Ulysses Burley, who is the CoVPN Faith Initiative Ambassador and the founder of You Be the Cure, LLC. I'm Mia Keys from the American Medical Association Center for Health Equity. As always, thank you for joining us on Fridays. We'll see you at the next conversation, and I'll hand back over to Brandon to close us out.
All right. Well, yeah, again, Mia and team, thanks for everything. We really do appreciate it. And if you need more information, preventcovid.org. I think Keiko and Dr. Wallace put that site up, so you can check that. We'll also, as Mia said, place this on our website and our YouTube page, so you can always go back and look at this Friday discussion or any Friday discussion. And I think, I like Dr. Burley's point that the elephant in the room in all these systems is racism. And Ray Bridgewater ended it in the comment section. Is like, well, we need folks like you guys, like Ms. Campbell, like Dr. Burley, like Dr. Wallace, like future Dr. Keys, to educate folks and make them feel comfortable so that we will have participation and diversity in these trials. So appreciate you guys for that and making sure everyone participates and is educated. Appreciate everybody if they go out and vote. Vote ahead of time, vote day of, whatever, just make sure you mail it in, just vote. And hope you have a good weekend. Thanks so much.